It's late one night. You're on the night shift. It might be the hospital, might be the SNF, the rehab, might even be the nursing home. Doesn't matter, but it's late. You're a little bit tired. The shift started out typical, usual busy, but you're still tired. You're a little bit hungry, and finally, you've gotten a few moments to sit down, take a bite to eat, and maybe catch up on some documentation. But then you hear it. It might be that bed alarm, might be a patient's voice, it might be your intuition. But whatever it is, you get up to go check on that patient who someone told you maybe earlier they were a little bit confused during the day, or maybe watch out for this person. But you go in, and that's where you find them in the room, trying to climb out of bed. You think, I've got to help them. I'm not going to let this go. You go over to help them, and you say, can I help you? You look like you need some help. You want to get out of bed. You have to go to the bathroom. Whatever approach you use, what happens next can sometimes happen. You might get a swing. You might get an angry yell. Get out of here. Leave me alone. So you stop. Then things get worse. Then the person starts to pull on their IV or their telemetry. Now what? Is this going to escalate, you think to yourself? The patient finally gets out of bed and wanders into the hall. Now you're thinking, this might get out of hand. Are they going to hurt themselves? Are they going to hurt someone else? Are they going to hurt me or my colleagues? What can you do in a situation like this? This is anything but easy. But there is a method called the TADA method, T-A-D-A. But let me warn you, it's anything but magical. It takes a brave heart, some creative thinking, and a lot of patience. But before we get to the ins and outs of the TADA method, let me tell you a little bit about where it came from. In 1997 at St. Louis University, we opened up an ACE unit, acute care of the elderly, a well-proven model to reduce functional decline in older patients who are hospitalized with medical illness. Very good model. We decided to add something extra to this model, something called the Delirium Room or the Delirium Intensive Care Unit. We were using a lot of one-to-one sitters at the time, and we thought rather than continue this, let's try something new, something a little bit bold and daring, I might add. So the unit has 21 beds. About half the beds are double rooms, and the other half of the wing are single rooms. So we took 2 of the 2 bedrooms on one side, and we knocked out the middle wall to make a 4-bed room. And that's what we called the Delirium Room. We did a lot of training because the intent was to have a nurse or nurse aide or some type of nursing staff in the room 24 hours a day. You can imagine nurses were not real happy with this idea, but the leadership said we should try it, and we pushed forward with this concept. Again, a lot of training, a lot of learning, but in the past 19 years and in the past 13 years from another delirium room we opened up at a hospital, a community-based hospital in St. Louis, we've learned a ton of things about the non-pharmacological management of delirium and even patients with dementia who may or may not have delirium. So the TADA method is actually a result of all these years' experience. There is some indirect evidence that it works, and I'll get to that a little later. But now, TADA, tolerate, anticipate, don't agitate. Tolerate. Tolerate means to allow a patient who might be confused to make meaningful, natural movements. Meaningful to them and natural to them. As a famous nurse in St. Louis once told me, every action has meaning. The challenge is, we don't always know what the meaning of that action is. So how do you tolerate this natural activity? We have to first understand it's natural for older patients and younger patients alike to get out of bed. It's natural to want to go to the toilet, especially at night. It's natural to maybe be hungry or thirsty and look for food. It's also natural for a person who might be confused to not understand why this person is in my room at night. And thus they might swing or say, get away. That's natural in some instances in their thinking. Now, of course, tolerate doesn't mean we're just going to sit or stand at the doorway and tolerate the person to get out of bed and fall. Again, the creative part of tolerate is rather than come on into the room and immediately jump in, as we normally do because we're caring caregivers, come into the room slowly, almost to the point or maybe to the point that the person doesn't know you're there. Get a little closer, watch what they're doing, tolerate that activity. Maybe we can get a clue from what they're doing. Get a little closer. Now the person is trying to get out of bed. Now they've got one leg over the side of the bed. If you're doing it right, you should have 3 bed rails up, not all 4. You don't want somebody to get trapped in the bed rail. Perhaps one side is down and one side is up. But you need to allow some movement. So now the person's got 2 legs over the side of the bed. And now they're trying to get their torso up. And now 10 minutes have gone by, maybe 15, and you're wondering, have I wasted my time that I could be doing some documentation or catch a bite to eat? But the beauty is that many times when you allow this activity to happen, the person will get tired. They get almost all the way up, they get tired, they lay back, boom. They might be down for a few hours resting. You help their legs back up, make sure they're safe, put the bed alarm on if that's what you do. But 10 to 15 minutes of tolerate may have prevented this escalation. Again, not easy. We don't want to tolerate unsafe movements or actions, but some form of tolerate could help us manage this patient without things escalating. A, anticipate. Anticipate is probably what we do best as caregivers. We know that someone is going to pull the IV or the NG tube or the Foley catheter, or worse yet. We know what might agitate a patient. So think ahead. Now, what can you do? We have to have IVs. We have to have telemetry. Sometimes people have to have Foleys or NGs. Well, think twice. Sometimes think 3 times. Does this patient really need the IV? Now, maybe they do. Maybe they need IV fluids, and there's no doubt in my mind that most delirious patients, if they're delirious enough not to eat and drink well, they're already dehydrated or going to get dehydrated. IV fluids is a very important part of trying to reverse delirium. But rather than hang the IV and run at 100 cc's an hour, or worse yet, 75 cc's an hour, thinking after 24 hours you're going to get 24 times 75 cc's in, we know after about 3 or 4 hours it's going to kink, the IV is going to get pulled, you've got to change the bag, etc. So try the bolus method. Not high tech, but we've done this and it's very safe. I know doctors are worried about heart failure and fluid overload, but you've got to convince them. A 250 cc bolus over an hour gets you more fluid than if you try to do it over 3 to 4 hours. Let the person rest, try it again in 3 or 4 hours, and boom, within the shift, you might get that 1 liter in that you were trying to get in anyway. Now, what if the person is pulling on that IV? Well, wrap it up. Anticipate that they're going to pull that IV. And this is a trick some of our nurses have taught us, is to use a decoy. You don't put the decoy IV in, you just put it on their arm or their wrist, somewhere where it's visible and obvious to them, and they might pick at that. And then you take the other IV, you put it in a safe place, cover it, and maybe you'll buy some time that way. Other anticipation, of course, anticipate hunger, thirst, toileting, bowel movements, things like that. So anticipate can go a long way. DA, don't agitate. Perhaps one of the most difficult parts of the TDA method, because we are good caregivers. We want to jump in, we want to help, we want to touch, we want to fix people sometimes. So, how do you not agitate someone? First method, first principle. Take your orientation questions, throw them out the window. I haven't done orientation questions in the hospital, the SNF, the rehab, the nursing home in years. I just haven't found them useful. Now, I still do orientation questions if I'm in the clinic and someone comes for an assessment of cognitive impairment, of course. Memory, orientation, executive function, etc., etc. But when you're in the hospital and you have sick people or in the rehab, think about how often that these orientation questions have helped. Rare. Now, there's once in a while a patient will ask you, where am I? This isn't my home, or I'm a little confused, and you can tell them, you're in the hospital, you're doing fine, you might go home in the next day or two, and they go back to sleep or they stay calm. But, as we know, sometimes the patient says, I'm not in the hospital, and what are we trained to do? We're trained to reorient. Try not to reorient. It can only, many times it will cause agitation. So what do we do if a patient is not oriented or confused? Try this. Next time you have to have an interaction or talk with a patient, let them lead the conversation or the interaction. I promise you this will help. This will help you figure out what's going on. Take this example. You go into a patient room, you're doing your normal rounds, you check on the patient, and your gut feeling is, your intuition is that there's something wrong. They're uncomfortable, they're restless, they just don't look right. You know. But what we're trained to do is go through a litany of review of system questions. Are you having pain? Are you hungry? Are you thirsty? Do you have to go to the bathroom? That's too much for the confused patient. Take a step back, take a deep breath, and sit down with the patient. If they're restless, take just a few minutes. Let them express themselves. It's hard to understand people sometimes, we know that. It's better just to get the yes or no questions. No pain, no hunger, toilet, yes. Oh, great, you fixed it. But when you're not getting that, let them declare themselves. What are they trying to say? You might get lucky. They might reach over and, this. You can't understand, but you can interpret what they're trying to say. So, try that method. Remember, don't agitate. It could go a long way. So that's the TDA method. Tolerate, anticipate, don't agitate. Is there evidence behind this? The data from our studies at St. Louis University and our community hospital, we've done 2 different studies, has shown that a delirium room, again using these principles, can reduce the length of stay of delirious patients. It can reduce the functional loss that often occurs with delirium. It can even reduce the amount of antipsychotics and other drugs we use for delirium. So we believe it's effective. The indirect evidence, especially related to the tolerate principle, is the immobility, the early mobility data from the ICU. ICU patients who are mobilized, even patients on the ventilator, mobilized early within those first couple days, any mobilization at all, compared to usual care, which usually takes almost a week sometimes to get them moving. The group that has early mobility has decreased delirium days, decreased stay in the ICU, and better functional status after they get out of the hospital. About 66%, 2/3, get their function back compared to about 1/3 in the usual care. So that's the direct and indirect evidence. The last piece of indirect evidence I can tell you is that in our delirium rooms, our restraints, our physical restraints, is near zero. The only time restraints get put on people is when a nurse who might not understand the concept of physical restraint-free environment is pulled from another floor or an agency, and sometimes that happens. But we're able to achieve a near 100% physical restraint-free environment for even the most delirious patients. And these are medical patients in our ward. Lastly, I need to comment about drugs used for delirium because we are medical caregivers. We tend to turn to medications for these problems. But again, I would like to emphasize our use is very, very low. And if you can use these non-pharmacological methods, again, you'll be able to avoid the drugs. We know the intention of the drugs are to make a cooperative patient that's not so confused. And if we think about that intent, we know there are no drugs out there that do that. Most of the drugs that are available have the side effect of sedation. They don't clear the delirium, and it's in the sedation where people are calmer. So please try to avoid the drugs. Try to pursue the Tada method. Practice it. It is a skill over time. It takes a brave heart and a lot of creative thinking. So thank you for listening. Again, thank you for your care of our elderly. It takes a special person to do that, and I know our elderly appreciate that. Thank you for inviting me to this conference, Chris and everybody else. I hope it goes well, and it was a pleasure to be here, even if virtually. Take care.